Welcome to this PCR Tokyo Valve 2022 webinar. My name is Lars Sandergaard. I'm a cardiologist based in Denmark, and today we're going to discuss the role of left atrial appendage closure in prevention of stroke. We have three learning objectives today. First of all, to understand how to select patient for left atrial appendage closure. Second, we're going to learn about how pre-procedural planning and post-procedural care after left atrial appendage closure is done state-of-the-art. And finally, we're also going to see a recorded case to see the procedural step for left atrial appendage closure. It's my pleasure to be joined here today by three very good colleagues here, Dr. Yamamoto and Dr. Hara from Japan, and also Karen Phillips from Australia to be part of this discussion here. We're going to build this session on a case. So let's have the slide up here. We can look at what case we're going to discuss today and later on also see how the procedure was actually done. So this is, I guess I can move it forward here, a 75-year-old female. She's on the smaller side. BMI is 20.1 kilogram per square meter. She got a story of paroxysmal atrial fibrillation. Her CHA2DS2-VASc score is 5. Has-Bled score is 2. And despite she has been on direct oral anticoagulation treatment, she had 3 strokes, 2 of them under appropriate treatment. And that's the reason why she was referred to us for left atrial appendage closure. We did an echocardiography showing a preserved left ventricular ejection fraction, 60%. Both right and left atria was dilated. She had a mild mitral regurgitation. She had a scan of her carotid arteries showing no significant plaque stenosis. And also her lab findings was unremarkable, despite apart from a mildly impaired renal function with an eGFR of 67. As part of the workup in our institution, we did a cardiac CT scan, which provided quite a lot of information. First of all, here you can see it's a chicken wing morphology of the left atrial appendage. And also it give us a possibility to have good sizing of it. Here you see the ostium, or the landing zone for a Watchman device, is 21 times 26 millimeter. And you can also actually calculate what is the perimeter derived diameter of this landing zone, which is around 23.5 millimeter. CT scan also give additional information. First of all, you can try to predict where is the optimal position to do your transeptal puncture in order to have coaxial alignment of your delivery sheath and thereby a more predictable implantation of the device. And in this case, it's an inferior but not too posterior puncture. So inferior and mid-septum puncture will give you the best access to this left atrial appendage. And also, one additional information you can get from the CT scan is where to position your C-arm, so you have a perpendicular view to your landing zone, the ostium of the left atrial appendage. And you can see in this specific case, the C-arm should be positioned in REO 26 degrees, but no cranial or caudal tilt. So I think we can stop here, and maybe before we go on, have a discussion between the panelists here. And I also want to say to you who's participating online, please feel free to use the chat function if you have any questions or comments, and we'll try to address this. So maybe I can start with you, Karen, here. We were saying that this patient had a CHA2DS2-VASc score of 5 and a Has-Bled score of 2. Maybe you can just explain how do we calculate these scores and what does they actually mean in patient with atrial fibrillation?
So hopefully a lot of people will be familiar with these scores, but yeah, to recap, CHA2DS2-VASc is a universally used scoring system to assess risk of stroke with atrial fibrillation, and the components are heart failure, hypertension, age, which in this case is double points for age over 75 years. Previous history of stroke, vascular disease, and sex, as females are known to have a slightly higher risk of stroke at a younger age. So generally, a CHADS-VASc score of 2 or greater is considered high risk and merits anticoagulation. And in this particular case, we've got a CHADS-VASc score of 5. And it might be interesting to revisit that later as to, potentially were all of her strokes related to atrial fibrillation. Often these patients have other vascular risk factors that could generate some of their risk of stroke. The has-bled score is another validated scheme for scoring a potential risk of bleeding on anticoagulation. And the components of that are somewhat similar to CHADS-VASc because they also include things like hypertension, but in this case it's uncontrolled hypertension, age over 65, previous history of stroke. So again, we're repeating some of these. So some of the risks for stroke are also risks for bleeding as well on anticoagulation. Patients who've already had bleeding history will be at higher risk of having further bleeds on anticoagulation. And then abnormal liver kidney function predicts increased risk of bleeding. And other drugs that patients may be taking, such as additional antiplatelet therapy, steroids, a range of medications which might increase bleeding risk. And generally, a score of 3 or more is considered to be high risk for bleeding. And that's not an absolute contraindication in itself, but it's a guide to watch out for those patients and maybe consider their options as you navigate stroke prevention and anticoagulation for those type of patients.
Yeah, that's great, Karen. So again, the CHADS-VASc score will tell you something about the risk of thromboembolic event in patient with non-valvular atrial fibrillation. If it's more than 2 or more, that you should consider all anticoagulation. And of course, these will also be the patient where you should consider left atrial appendage closure as an alternative treatment. Has-bled, what is the patient's risk of bleeding during oral anticoagulation? And that can, of course, also be an indication for looking for alternative way to prevent thromboembolic event. So, Dr. Harrer, that's different indication for doing these procedures. And I think in many countries, it started out looking for patients who had what we today call absolute contraindication for oral anticoagulation. Can you tell us about who are these patients, and are these the patients you offer this treatment for in Japan?
Oh, yeah, thank you, Lars. So, yeah, Japanese guideline is saying a little bit differently because they recommended to perform this kind of left atrial appendage closure to the patient with CHADS-VASc greater than 2 or more, and also at least has-bled 3 or more. So that means genetically, East Asian people are prone to bleed. So we are really focusing on the bleeding. So left appendage closure, the working group should, they are thinking the left atrial appendage closure should be done to the patient with a high bleeding risk or bleeding. So that is one of the absolute contraindication of DOAC. And yes, of course, the absolute contraindication of DOAC, there are so many absolute contraindication like hypersensitivity or drug interaction, etc. But yes, again, I would like to focus on bleeding because if we look at the IFE of DOAC, the current bleeding, such as intracerebral or GI bleeding, those are events which reduce their life expectancy. So that is absolute contraindication. And also, if patients have not a current bleed, but a clinical relevant organic lesions at high risk of bleeding, that is one of the contraindication of DOAC. In such population, we need to undergo left atrial appendage closure.
So how is it in Australia, Karen? What kind of patient are you looking for here? Is it also patient at high bleeding risk, or is it patient at what we call absolute contraindication for oral anticoagulation?
Well, Lars, I want to make the comment first. Unless people are familiar with all of the evidence base behind left atrial appendage closure, the original studies performed with the Watchman device showed that it was a good alternative to warfarin. Most places around the world, though, we've ended up somewhat based on clinical guidelines that maybe the first place we should be using this therapy is in patients who can't take anticoagulation. And that's the current clinical guidelines suggestion. And many, I guess, regulatory restrictions have been put in place, and that includes Australia, that we are not permitted to offer this as a general stroke prevention treatment. It can only be offered to patients who have absolute contraindications, a valid reason why they can't take anticoagulation long term. So generally that translates into bleeding problems. I think that's that knee-jerk reaction that when a patient has a problem on anticoagulation, then you reach for the alternative afterwards. That's the essence of practice in Australia.
Yeah, and I think that's the same in Europe. I mean, according to the guidelines in clinical practice, most of the patient who's offering left atrial appendage closure is patient what we call who are at absolute contraindication. Patients have severe bleeding, GI bleeding, intracranial bleeding during anticoagulation. So these people are often left without any protection for thromboembolic events. So even though it's the general practice in Europe and also, as you said, in Australia, the interesting thing is that we have actually no evidence for the therapy here. I think the trial came out too late. Boston Scientific tried to conduct the ASAP-2 study randomizing these patients to left atrial appendage closure versus just best medical treatment without oral anticoagulation. But it was too late. The study didn't manage to enroll all patients and was terminated prematurely. So we actually don't have evidence here, but I think clinical practice also show that there's certainly a role for doing the procedure in these patients. But moving to what you were talking about, not patients who have absolute contraindication, but patients who have high bleeding risk. So patients who potentially can go on it, but we know that these patients are at a high bleeding risk. Dr. Yamamoto, understand that these are the patients you're looking for in Japan mostly to offer left atrial appendage closure?
Yeah. Before talking about the high bleeding risk of OAC, I would strongly, the presented case is definitely a good indication of the LAC procedure. And please, Dr. Hara will change the indication of LAC in Japan. And anyway, I want to talk about the high bleeding risk during OSC. And first of all, we Japanese or Asian cohort are rarely high bleeding risk cohort. For example, in PCI field, 64% of patients are considered in Japanese criteria of high bleeding risk patients. And especially in elderly TAVR cohort, more than 90% of patients are considered the Japanese high bleeding risk cohort. That is the current situation in our daily practice. So how about in some Europe or outside of Asia?
Yeah, but I think particularly if you go to the US, it's also those patients who are, according to the guidelines, are offered left atrial appendage closure patient at high bleeding risk. And can you just refer to that study which actually gave indication that protected AF? Maybe you can just shortly summarize how this was designed and also the limitation behind this study.
Well, Protect AF was published back in 2009 now, and it was really the pivotal randomized control study which showed proof of concept that if you can put a device into the left atrial appendage to effectively seal it off, then that represents a suitable alternative to anticoagulation. And if everyone remembers back that far, we were using warfarin at the time. It was before, DOAC therapy came along. So randomized controlled trial of the original Watchman device, not the second version that we're going to see in the case today, versus warfarin, and followed up over time and showed basically equivalent outcomes for all-cause stroke. There have been multiple other studies performed. There was a second randomized controlled trial, PREVAIL, And some of these additional studies were basically required in the US for, FDA approval. And left atrial appendage device closure really didn't become commonplace in the US until 2015, whereas in Europe and even in Australia, we were implanting the Watchman, from 2009 onwards, really, as soon as we had that data from the original trial. So the evidence started out with an alternative, but it's taken us quite some time to see perhaps left atrial appendage device closure more widely used, that we're still focusing on patients who can't take anticoagulation. But some of the newer evidence includes the Prague 17 trial, which was performed closer to you, Lars. So based in the Czech Republic, comparing left atrial appendage device closure that included Amulet and Watchman compared with current standard anticoagulation, which is NOAC, which predominantly Eliquis, and the device closure holds up well compared with NOACs these days as well.
Yeah, so I think even though we have evidence that left atrial appendage closure is non-inferior to anticoagulation, the problem is that it was tested against warfarin, which no one is using anymore. It's DOAC, and as you said, the Prague 17 study showed that it was at least as good as DOAC to do left atrial appendage closure. It was a quite small scale study. There are two large scale studies going on right now. Boston Scientific is conducting one of them, the Champion trial, and Abbott the other one, the Catalyst. And hopefully when these are enrolled, we're going to have much stronger evidence whether left atrial appendage closure is at least as good as DOAC patients and DOAC to these patients at high bleeding risk. But also, we saw this specific case here, Karen. A patient which 75 years of age, have actually no bleeding, but she had 2 strokes despite appropriate DOAC treatment. Would she be a candidate in Australia for this therapy?
Well, that's a little challenging. We all have to stick to the rules to some extent that are set out for us. I think many of us in this field recognize patients who are probably worthy of this treatment, but maybe don't fit those rules exactly. This type of patient, there certainly is a chance that she could have been having strokes for other reasons than her AF. Maybe that's why the DOAC, treatment wasn't effective. But we still do know that anticoagulation isn't 100% effective at preventing clots in the left atrial appendage for atrial fibrillation. And so sometimes closing off the appendage is the best way to mechanically stop that static situation. And often the left atrial appendage can almost behave like a clot factory, that despite anticoagulation, you can still get clots forming. And if we can close off that whole area, it will reduce the chance of clots. The question I think we'll have with this case is, because this patient can still take anticoagulation, and I'll tell you, I certainly have done cases like this in the past, even though it's not exactly in line with Australian rules. But often I choose to keep the patients on anticoagulation, on some form of anticoagulation afterwards, and that way we've got double therapies for stroke prevention. So I don't know what everyone else's thoughts and practice would be around that scenario.
Yeah, Dr. Yamamoto, will she qualify for this procedure in Japan?
And should we discuss about the procedure plan for this case?
No, I'm just saying that this patient who had stroke during oral anticoagulation therapy, would she be a candidate for left atrial appendage closure in Japan?
Yeah, and I would introduce the interesting report of in Japan, from Japan, the more than 500 patients with AF. And the transesophageal echo identifies that after the anticoagulation for 3 weeks, and 2.7% of patients are still recognized as a thrombus. So during the appropriate anticoagulation, the risk of the stroke still existed. And I think this case is definitely a very good indication for LAC procedure.
Okay. So also, Dr. Hara, we saw that the case presentation that just showed was based mainly on CT scan, but many sites will use echocardiography specific transesophageal echocardiography for the workup. How is the situation in Japan? What is the procedure planning based on?
Oh, yeah, thank you so much for asking I think procedural planning for appendage closure is still transesophageal echo in Japan, but there are so many centers using the CT scan beforehand. So, but there are some of the advantages on transesophageal echo because we can assess not only the pre-procedure, but also during the procedure using transesophageal echo. That means that we can get a consistent evaluation regarding the appendage anatomy. The other one is we can assess not only anatomical but physiological data, such as left atrial appendage velocity or velocity of the leakage, etc., on the esophageal echo. And the other one is we can choose no radiation exposure strategy using the transesophageal echo. And also, no contrast media can be given when we choose the transesophageal echo. Those are advantages of the transesophageal echo. But of course, there are some limitation of the TE because that is a semi-invasive strategy. Actually, a couple of years ago, I had transesophageal echo twice, but that was very painful and I almost threw up at that time. So that is one of the disadvantage of the transesophageal echo. And also this is rare, but there is some potential to cause complication like pharyngeal bleed or esophageal bleeds, which sometimes become an issue because the patients are having the OARC. So I think many countries in Asia are still in COVID era, and also some are still difficult to perform in many centers from the point of view of infectious control. That is the situation in Japan.
Yeah. So I mean, you nicely highlighted some of the pro and cons for each modality, transesophageal echo, CT scan. How is the situation in Australia, Karen, for the workup and procedure planning? Using echocardiography or using CT, or is it a combination?
Yeah, it varies, and it depends on access to transesophageal echo, which would generally be done with deep sedation and an anaesthetist present. CT scan is generally an outpatient test, so easily accessible. That's certainly my preference. I'm an electrophysiologist. I do AF ablation, and we've been doing pre-procedural CT scanning for all of the cardiac navigational systems for a couple of decades now. So the CARTO and EnSight systems that we use for the navigation and ablation, we've been able to upload CT scans, do really nice 3D rendering, and turn these anatomical images of the left atrium around, for 2 decades now. So I accessed that type of technology early on to have a look at left atrial appendage anatomy. And most of that's qualitative, being able to assess where you think you'll need to do your transeptal puncture and what you think the challenges of the particular anatomy of the appendage will be. One thing we haven't probably covered is ruling out left atrial appendage thrombus before we instrument with the procedure. Certainly, there are some centres who don't do any planning at all. Obviously, if you put the patient on the table and you find that they have thrombus at the time, you have to cancel the procedure. And that's a real shame if you get to the actual procedure, date without finding out that information. So I think most centres would still prefer to do some sort of imaging prior. And the choices really are transesophageal echo or CT scan. And CT scan, if done with a good contrast protocol, is basically equivalent to transesophageal echo for ruling out thrombus prior to the procedure.
Yeah, That's correct. And also, I mean, it's also people who's coming from also from a structural background, structural heart disease, doing, let's say, transcatheter aortic valve implantation, would never engage in a procedure without having a CT scan prior to the procedure. And I think if you have done it, you will see nowadays it's the burden of radiation is very small. It's a small volume of contrast. And I would almost claim that if you do your CT scan, you're going to save radiation, you're going to save contrast during the procedure because you have so many information up front, which is going to make the procedure much more predictable. So let's get back to the patient. We have a 75-year-old female. She have a paroxysmal atrial fibrillation. We can just go a little bit back and just see the slide once again here on the patient. During all anticoagulation, she had 2 episodes of ischemic stroke. High Chad vascular, so there's certainly an indication for doing something to prevent thromboembolic event, oral anticoagulation or left atrial appendage closure. So, Dr. Yamamoto, according to the current guidelines and clinical practice in Japan, would she qualify for left atrial appendage closure?
Yeah, as Dr. Hara mentioned, the more than CHAS-VASc 2 and Hasselblad more than CHAS 2 score more than 2 and Hasselblad score more than 3 is a good indication for the LAC procedure. And other recommendation is a frequent fall or some prolonged the dual antiplatelet therapy. For example, the left main coronary stenting or multiple overlapping stenting. So not only the indication of the Japanese guideline, but also in our daily practice, many patients should be received the LAC procedure more and more. So, and many considerations should be determined by heart team approach. And we are now struggling about it, but I do believe the LAC procedure is a very good option for the high bleeding and high stroke embolic risk stroke patients.
I agree. So still, despite we don't have any evidence on this specific patient cohort randomized trial, I think in many sites who do this procedure will accept this patient for left atrial appendage closure. So let's get the slide back on and we can discuss how this procedure was actually planned. I'm just going to go a little bit forward here. We have seen this slide. We're going to do it using the Watchman Flex device from Boston Scientific. And maybe Dr. Harry, you can just explain how this device is designed and also what is the difference between the Flex and the previously Watchman device.
Oh, yes. Yes, when you look at this slide, you can see the top of the fabric area, whitish fabric that is made of polyethyl terephthalate PET. And this membrane will face on inside of the left atrial appendage, left atrium cavity. And this strut part is gonna be sitting inside of the deep inside of the left atrial appendage. And also the difference between the previous 2.5 generation Watchman and this type of the Flex device, the majority of the changing is here, or the tip of the distal tip of the device, because it is round shape and a closed shape that will make less injury inside of the left atrial appendage. And we can push with advanced method to deploy the device. That is a major advantage of this device. And of course, we can do the full recapture, and we can try again and again. That is a major advantage of this device. And the other part of the advantage is the rows of the anchors. The first generation, 2.5 generation, the Watchman has just one row of the anchors to reduce embolization. But this Flex has 2 rows of anchors that will make less embolization. That is another good advantage of this device. And lastly, I'm gonna talk about the strut frames, number of strut frames. The previous generation has only 10 struts, but now we have 18. So that will fit the left atrial appendage wall very nicely to reduce the leakage. those are major advantages of a flex device, I think.
Yeah, I think that was very nice summarized, Dr. Harris. So certainly one of the issues also in the protected AF trial we discussed earlier on was the safety of the procedure, the risk of perforation with hemopericardium, device embolization. And I think we have seen these newer generation devices which are much more safe to implant with less complication and also more efficient in order to prevent peri-device leak. Of course, there was also a learning curve from the community who's nowadays more skilled, but this is certainly a major step forward to have this Watchman Flex device. So one thing you can also use your CT scan for is to try to have a more advanced planning. So quite a few sites were nowadays looking at this, what we call computer modeling. So here you can see there's two device sizes tested here. The first one was the Watchman Flex 27 millimeter implanted in a proximal or distal position to look at the rate of compression of the device and also how much of the device is hanging out into the left atrium, and also try to look at a bigger device, the 31 millimeter flexi, again in a proximal or distal position. And based on these computer modeling, it in this specific case was determined that for this patient, a Watchman Flex 31 millimeter in the distal position would give you the best compression rate without having too much shoulder out. So that was actually used here for planning procedure, not only choosing which brand you're going to use, but also what size and where actually to implant the device in the patient. So this is the procedure plan here. It's going to be done in local anesthesia. Patient is fully awake because we have all the information we need from the CT scan. We do not need sizing during the procedure. We can just use intercardiac echo for guide transeptal puncture and device implantation. Transeptal puncture was also determined where to do it. We're going to use the new VersaCross system to do it. And then, as I said before, to implant a Watchman Flex 31 millimeter in a distal position. So maybe we should just look at this recorded case and we can discuss afterwards what is the difference between this case and how things are normally done in Japan and in Australia. So if you can start the case now, please.
I'm here with my two colleagues, Gintas is here and Ole de Backer. And we also got our imaging expert, Niels Weisrup, is here. Ole, just tell us what you actually have done so far, what you're doing now.
Well, very short, we just have two venous accesses. In one, there's a 10 French arrow sheet for the eyes, what Niels Weisrup is having the eyes catheter in. In the other one, I just introduced the VersaCross sheet and wire. And that's what you see on the fluoro. This is that pre-shaped VersaCross wire I'm bringing down here. That has a very small radio frequency tip. I'm pulling this into the sheet now. It's a pre-shaped sheet.
Okay, so first of all, you see the guide wire. There's only one guide wire. You see they have a loop on the end. So first of all, you can safely introduce it up to the SVC, and you can, and also when you come across, you can use that to pass your sheet into the left atrium. It's also attached here at the end to a radial frequency. So we're not going to puncture with a needle. We're just going to push the wire against the septum, apply some RF energy for a second or two, and then we'll make our way through the septum. So it's a more predictable way to do it. And I think we are now...
Yeah, you're across.
Yeah, so you see the sheet is now across. Ole can advance this wire into the to the left atrium, and now it's actually up all the way up in the upper pulmonary vein. And we can use the same wire to introduce our sheet, the delivery sheet, our true seal delivery sheet here in a second. So it's less exchanging of guide wire and catheters during your transeptal puncture. So that's the whole concept about this VersaCross system here. Now, Gintas is taking this the delivery sheet for the double curve, yeah.
Oh, just
and the radio frequency applied to this wire, correct?
Say again, Mohammed.
Niels is already across. Hola.
The radio frequency is applied to the wire?
Yeah. You saw that at the tip of the wire. Maybe you saw that in the beginning. It was attached here to the tip of the wire in order to do that. So
Så vi bredt lidt her, Niels, nu.
So now Ole is advancing the delivery sheet across the septum here. And he will use the sheet to dilate. Can we see eyes at the same time?
Yeah, now it came through.
Yeah. So now you see it's across. Next step will be for Ole to leave the wire, but pull the sheet back. And then we're going to ask Niels to follow that guide wire into the left atrium. So we only have one transeptal puncture. So for Niels, it's a combination of looking on his eyes images and also that Ole is going to provide some fluoro guidance here.
Yeah, now it's across. You can follow
so
the
now
wire.
Niels is across, is that correct, Niels?
Yeah.
Niels is in the left atrium. So next, Ole is now re-advancing the delivery sheet back across the septum. So you see both the ice probe and the sheet is across the same interatrial septal puncture.
Apron.
Yeah, apron is fully given. Yeah.
So now we can take the wire out and make sure there's no air in the system, of course. And next, we're going to engage the left atrial appendage. The way we do it here in this institution is always to have a pigtail first in order to have a safe introduction of your delivery system into the left atrial appendage.
Yeah, we're in. I'm pretty sure. Yeah.
So Ole now believe he's in the left atrium, and we can ask Niels on to have a look on
the left atrial appendage.
Yeah, Niels can confirm that. Niels, just tell us the landmark you see on eyes here from the left atrial appendage.
Yeah, what we are looking for is the circumflex. Let's see if I can get a pointer over here. So we are looking into, I'm just standing outside the appendage. And here we have the circumflex, which we use as a landmark. And in a minute, I'll try to get a better view of the ridge, which is up here. But this is the left atrial appendage. And here you see the aorta. So what I'm looking at now is what on TOE would be a 45-degree view of the appendage.
So let's just let Ole tell us what he's actually doing now. And we can focus both on your hand, on eyes and fluoroscopy, and tell us step by step what you're actually doing, Ole.
So what we did is we kept the delivery sheet in the appendix, of course. We don't have to go necessarily very distal, but just mid somewhere. Then we introduced this watch device. I will pull it slightly back. Then you see there's a ring on it, you see? So when we push it forward, we want to end ring to ring. So the ring of the Watchman flex, the most distal ring, falls together with the distal ring of the delivery sheet. On this moment, maybe it's good to zoom in on my hands. Then you have this this part, the most distal part, which is the Watchman flex. This is the hub of the delivery sheet. So we hold the Watchman flex device, yeah, and we're gonna pull back the delivery sheet until it makes a small click, like this. Okay, good. Now it's clicked. So now this is frozen, and now we can just go really to the pin actually, which controls the Watchman flex device. Let's have a look. I think I'm deep enough in also on eyes, I think. So I'm gonna pull back mostly, slightly forward push until we have the ball shape. That's the new thing with the Watchman flex, of course. This is also a soft, closed distal end. Maybe it's a good moment to have a small look here with a little bit of contrast.
Mm. And also with the new Watchman flex, it's more forgiving. You have this atraumatic distal part, so you can also push a bit forward if you need it. Yeah, you see those 3 rings on the delivery sheet. And that's, depending on what size device you're going to use, should be approximately at your landing zone or your So Ole is placing that ring in where he wants to end up. And then there's two ways you can, you see here what is mostly done now is just to unsheath the device. And you see now it's out here. And you can also clearly see here, if you look at the configuration of the device, it is probably about 30% oversizing.
Yeah.
So Ole, you have done implanted the device now, and what do you see? Are you happy about the position? Can you just take us through it?
Yes, I mean, this is indeed, we know there was some compromise to make here from how proximal we can go or not. Our aim is, of course, to cover all the trabecals. I think we do that. We see a nice compression. What is also important that we have, so compression-wise, I think this is almost going to that kind of clock or bell-shaped. So that's roughly 30% compression for sure. What's also important is that we don't have too much shoulder. So I would call this only a 10% shoulder. You can go accept quite a lot according to IFU. You can even accept up to 30% shoulder, but typically that's not what we prefer to. So there's a very mild shoulder.
So when you talk about shoulder, it's a part of the device sticking into the left HM.
Yeah, exactly. And that's typical at the mitral side, at the inferior side. Yeah. So I think we're very happy with this. We're going to do a tuck test.
So before you do that, maybe you should just go to Niels. Can we see eyes in big images? And Niels, you can tell us what you actually see on eyes on the device position.
Yes, I'm in the left upper pulmonary vein. So this is the ridge where the arrow is now. And here's the device with the nice compression in the appendage. The circumflex is in this area. And this is the aorta. So I would say that it's well within the circumflex, the device at the moment. Yeah. I put Doppler on it, and there's no leak past the device.
Can you try to put some Doppler on it, so color Doppler, so we just can see, Niels?
The flow up there is the pulmonary vein. So we are going to look down here to see if there's any flow past the device.
So on the top, you say that's the pulmonary vein coming in. And then...
And so we would be looking for would be underneath this membrane, and I don't see anything.
Yeah.
Also, which is new with the Watchman Flex compared to the Watchman 2.5 previous generation, is that the cover over the Watchman Flex, it goes all the way to 1/3 of the device. It's not like halfway of the device. So that's why they recommend, they say that you can accept a shoulder up to 30%, but it's preferably not to have it. So I think really I'm very happy with this position. Then we can see indeed that there's, I do a very vigorous injection of the contrast. But what is a very important sign is here more the washout. So the fact that you have that staining of that contrast and very slow washout, that's a very good sign. And that's typically indicating that we will obtain complete LA closure with follow-up. Yeah.
Okay. So
and also what is important in this Watchman Flex, there's even a nice publication from Jacqueline So about this, that a Watchman Flex device, or that's valid for every LA device, if you can implant it in the coaxial with the axis of the LA, that's the case where you will obtain complete LA closure. And I think we're sitting very nice coaxial with the axis of the LA. So that's also a good thing, I think. So I did a good tuck. I didn't really see it moving a lot, to be honest. Of course, you see it always moving, but that's because you have the pull, but then it came back into its normal, natural position, also on eyes, I would say. Yeah.
So it fulfilled all the criteria for a good anchoring. You're not concerned about device embolization. So,
no.
So we can probably release the device.
Yeah. The last thing I do before that is going close to the device with my delivery sheet, give a small push on the device, so you have that maximal invagination and the maximal the anchors, because there's 2 rows of anchors that they're maximally anchoring into the trabecals of the LA, and now I think we're ready for release. Okay. So we're going to do that. I think this is still according to our simulations as well. So the cover is definitely still covering up this appendage, and we have a very nice closure, I think.
So let's just Niels, just show us once again on eyes whether you're happy about what you see here.
Yeah, I think it's a good position. I mean, some devices you would like to cover the ridge. The ridge is up here, but that's not the case here. We have the circumflex down here. This is the mitral valve, so this is the perpendicular view of the appendage, and I think it's filling out. I see no gap. I've looked for flow across, and it seems to be in a good position.
Okay.
Okay, so you saw this example of using the left atrial appendage closure for the Watchman flex for left atrial appendage closure. So, Dr. Yamamoto, how is this procedure executed here compared to how it's done in Japan? Is it very similar, or is there some significant difference in the way you do it?
Yeah. Thank you very much. It's quite different from Japanese style because probably 99% of patients are performed under general anesthesia with TEE guidance in Japan. And in some centers are trying and struggling to use ice during the LAC procedure, but I think it's still challenging. And I would like to ask the rest of Japan, what is the percentage of the local anesthesia and the general anesthesia, and what's the percentage of the uh, during conversion during the procedure from local anesthesia to general anesthesia, which means we need the transesophageal echoes findings in detail. But it's quite different. But I'm rarely learned, and I would like to use the ice during LAC because I would like to do the procedure in local anesthesia.
Yeah, I think that was, at least in our institution, the main driver to move to local anesthesia was to try to open up for more slots for left atrial appendage closure. It's a faster procedure and you're not depending on anesthetic team. Ken, I know you are an electrophysiologist in Australia. How are you doing these procedures? Are you doing it as a combination with your EP procedures, or is it a standalone procedure?
The answer is both, yes. So I commonly do AF ablation, and there's certainly a patient group who are interested in ablation for rhythm control, as well as have needs for stroke prevention that crosses over to left atrial appendage device closure. We have to use anticoagulation after AF ablation to protect the left atrial treatment that we've performed. So that's probably one key difference, that if you're doing device closure with AF ablation, this is a patient group who have to be able to take DOAC for at least a short time after these procedures. I commonly use ice during AF ablation procedures, and I've done a handful of cases really for device closure, but we are very spoilt. I have a general anesthesia available all of the time. I have good transesophageal echo support, so I continue to use transesophageal echo guided imaging for the device closure procedures. I think I'd make the point, and you saw that during the case presentation, that the views are much more limited on ice. In this particular case, we only saw one view. It is possible to manipulate the ice catheter to be able to see maybe 2 or 3 different views, but certainly not the 4 views that we're used to with transesophageal echo. So if you're using an ice-guided procedure, it's so important the CT-based planning you did beforehand. You have to do a lot of extra planning to make up for the limited views that you will get on ice during the procedure.
I fully agree, and I think that's a perfect combination to doing the CT scan and the ice, because you cannot get those measurements reliable on ice. But no matter how you're doing, I think it has to be tailored to each individual institution to make sure that you actually have a safe setup for this, whether it's in general anesthesia, local anesthesia, guided by TE, or guided by ice, is coming second to a safe and effective procedure. There's some questions here from the chat. There's one here from Lithuania, Dr. Bajoras, asking what kind of antithrombotic therapy would you commit this patient on after a procedure like this?
All right, well, that's always going to depend on the individual patient. As we've heard, many of the patients who get referred for left atrial appendage device closure either have had significant bleeding problems or at high bleeding risk. And we really want to be careful about not being too heavy-handed with antithrombotic therapy after these procedures. We are concerned, however, about device-related thrombus. If people are familiar with this field, it is certainly something that we see with imaging follow-up, and in part that's because we've been very conscientious with following up the results of a device-based closure. And if you do CT scans and transesophageal echoes in these patients 6 to 8 weeks afterwards, you sometimes see thrombus or what looks like thrombus lying on the outside of the device. Luckily, only the minority of these device-related thrombus seem to cause any issues. So I don't know if you can pass on to the next slide, the evidence base. So we do have some evidence to guide antithrombotic therapy after these procedures. One of the guidance is what is the risk of device-related thrombus? And this is basically a summation from all of the large Watchman trials, an analysis of what percentage of patients were detected with device-related thrombus, who had problems, and what are the risk factors for DRT, device-related thrombus. So in this cohort of studies, 3.7% of all patients with a Watchman implant were picked up with device-related thrombus. But I think it's important to note that only a quarter, so 26% of these patients actually suffered a stroke or some problem as a result, it seems. And from this study, the clinical predictors, so who seem to be at high risk of developing device-related thrombus, and it's a lot of conditions that probably predict stasis. So permanent AF, a previous history of stroke already, really large left atrial appendages, which probably have static, conditions, decreasing left ventricular ejection fraction, so heart failure, poor circulation, and also patients with vascular disease. So it's worth keeping in mind that, patients that have these characteristics could be at high risk of device-related thrombus and may need, more intensive antithrombotic therapy. Jump to the next slide, Lars. We have more evidence about what therapy we should be using. Empirically, antiplatelet treatment has been used. That was what was used in other structural heart cases when we were closing PFOs or atrial septal defects. So maybe that might be sufficient for left atrial appendage closure. But this was another study that came out of all of the Watchman trials, a propensity matched comparison of patients who were given oral anticoagulation versus antiplatelet therapy. And what you see from the graph here is freedom from device-related thrombosis. And the red line is oral anticoagulation, and the blue line, which drops lower, meaning more device-related thrombosis, was patients on antiplatelets. So, Lars, you were first author on this paper, but it's, I think an important piece of evidence that suggests that antiplatelets may not always be enough to protect against device-related thrombosis. And next slide. This is some exciting evidence. Next slide, Lars. Will it advance?
Thank you. That's fine.
So yeah, this was only published last year. So it's an innovative approach which had a look at half-dose DOAC versus antiplatelet therapy. So maybe after the appendage is closed, we don't need full-dose anticoagulation. So this was a direct comparison of antiplatelet therapy and half-dose DOAC. And it showed basically same as the propensity-matched analysis, although this is a direct head-to-head. So more patients had device-related thrombosis on antiplatelet therapy than on DOAC. And the half-dose DOAC, you see the graph on the right-hand side, half-dose DOAC had reduced bleeding rates even compared with antiplatelet therapy. So this might be an innovative approach for antithrombotic therapy that balances the risks in future. And next slide, Lars. And this is really what it's all about, on a case-by-case basis, what's the patient's history and risk of bleeding afterwards, and what's their, risk of stroke and device-related thrombus, and how do we balance that off with what we hope is only a short period of antithrombotic therapy while the left atrial appendage device heals in. So I'll open it up to everyone else to say what they might do in this particular case, and perhaps what they're doing routinely in terms of antiplatelet or DOAC or half-dose DOAC treatment for their patients.
So maybe you, Dr. Hara, will say what's your practice for these patients? How do you treat them afterwards, and for how long?
Oh yeah, thank you so much. So yeah, actually, at first I followed the medication resume regarding the protective trial, like a protective trial. That means 45 days aspirin plus OAC and double antiplatelet therapy for 6 months. But now I prefer to use like champion F like medication and a little bit longer anticoagulation prescribed, and then I'm gonna change to the antiplatelet. But I'm really agreeing with the half DOAC strategy. So in some patients, we are using this strategy in my daily practice.
So for most patients, you will start out with oral anticoagulation for 45 days, and then you will go to antiplatelet therapy.
Yeah, that's right. At least we are using at least 45, but it depends on the bleeding risk. Yeah, some patients has just 1 week anticoagulation, and I could stop everything because of the severe bleeding. So I think it depends on patient and patient to patient condition.
Yeah. And I also think, it of course also depends what kind of patient you're treating. Patients who have a high bleeding risk will potentially tolerate a couple of months on oral anticoagulation. On the other hand, you have the patient we often see in Europe, patients who have what we call an absolute contraindication. And I can see in Europe, people down trimming at some sites, but only giving aspirin afterwards, and even stop the aspirin after a while. So again, I think the most important is to look what kind of patient you have in front of you, and try to, with those limited limitation you've got, to try to tailor the best antithrombotic therapy afterwards. Dr. Yamamoto, one of the things which can actually prolong the duration of antithrombotic therapy is period device leak, if it's not efficient. So how is it in your institution? How do you perform imaging after left atrial appendage closure, and when do you do it?
Yeah, it's a really complex situation in Japan because the Japanese Circulation Society recommend us to check many times, 40 days after LAC, and 6 months after LAC, and 1 year after LAC. We have 3 times imaging check in general. But if we choose the transesophageal echo, patient is claimed always, and it's a very it has a problem for us, and I'm not sure the appropriate timing of the imaging modality, but I think the frequent imaging check is not mandatory for the patient. I think that, so like what champion trial study, for example, the 3 months after at 3 months checking the transesophageal or CT scanning checking, and discontinue the oral anticoagulation. We need to check the existence of DRT for after the discontinuation of OSC, and it's enough to check. So our daily practice is many times imaging checking is so many times it should be prevented in the future.
Yeah. So you said now it's about 45 days after, 3 months, 6 months after, 1 year after. What are you looking for?
Yes, yes.
What are the things you're actually looking for on your CT scan or your transesophageal echo? What information do you want to have?
Yeah, I prefer the CT scanning, of course, because the patient don't want to receive the transesophageal echo, and the incidence of the DRT is in our center approximately 200 cases already performed, and only 2 to 3% of patients had a device-related thrombosis. So it's such extreme low rates of the device-related thrombosis. We don't need so many times imaging modalities, I believe.
So as you said, the most important thing is to look whether you have a complete sealing. Of course, if you have a big peri-device leak, you should consider whether this therapy is efficient, or you should continue on oral anticoagulation. And then, of course, you can look for device-related thrombosis. I think we're coming to the end here. If I should just summarize what I've seen here, you have seen that there will certainly be a quite big group of patients out there with atrial fibrillation at high risk for thromboembolic event, but also have bleeding issues. It could be a high bleeding risk. It could be also be a patient who have absolute contraindication of oral anticoagulation. There could be the patient we saw here, where oral anticoagulation for one or the other reason doesn't seem to be efficient. And for these patients, consider whether left atrial appendage closure can actually be offered for these patients and protect them against stroke. You see with a good workup, whether it's transesophageal echo or it's CT scan, you can have a very detailed information, and you can often have a very predictable, very safe procedure for these patients. So consider that when you meet these patients in your daily clinical practice. I want to thank you, Dr. Yamamoto, Dr. Hara, you, Karen, for being part of this discussion, for all of you who participated in watching it, and also for both to Boston Scientific to facilitate the webinar here, and for Tokyo Valve. So thank you, everyone. I hope you was useful to watch this webinar.